Hello and welcome to DAS Health's webinar, MIPS and CHIPS, Lunch and Learn for the Quality category. My name is Bridget Peterson and I am part of the Government Incentives team for DAS Health. Before I get started, I would like to take a moment to explain the process for today's presentation. First, I would like to mention that this webinar will be recorded. We'll send out a copy of the slides and recording within the next week. Next, for those of you who aren't familiar with DAS Health, I encourage you to visit our website, connect with us on LinkedIn, and subscribe to our YouTube channel, where you can access all of our historical webinars. I also want to mention the upcoming educational webinar series, MIPS and CHIPS, a lunch and learn series on each category of MIPS that we'll be presenting in May and June. I know we're kicking this off today, but the next categories we will cover will be the Promoting Interoperability category on Wednesday, May 17th, the Improvement Activities category on Wednesday, June 7th, and the Cost category on Wednesday, June 21st. We will also have a traditional hour-long webinar on Achieving NCQA PCMH recognition utilizing Aprima on Wednesday, June 14th. We will be sending out an invitation to each webinar a week or so before, and we always post on our LinkedIn page as a reminder, so keep your eyes peeled for that. Okay, so back to today's webinar. Our first one focused on the quality category as part of our MIPS and CHIPS Lunch and Learn series. If you have any questions, please feel free to use the questions area of the webinar control panel, and we will answer all questions as they come in. Finally, for audio clarity purposes, everyone's phone will remain muted throughout the entire webinar. If you are experiencing audio issues, please use the chat box to let us know so we can help resolve them. And again, questions may be entered in the question box. So without further delay, I would like to introduce our team who will be your presenters today. Myself, Bridget Peterson, a Government Incentives Consultant, Lindsay Lanning, our Government Incentives Manager, and Kimmy Watson, our other Government Incentives Consultant. We have all been working with MIPS, PCMH, and many other quality reporting programs for years, and each have our own areas of expertise. And we are very excited to help your practice in any way we can. So Lindsay, the webinar is all yours. Feel free to get started when you're ready.
Perfect. Well, thank you so much, Bridget. And, thank you everyone for joining us on this Wednesday afternoon for our deep dive into the quality category. You all are lucky today. It is just me, or unlucky really, I should say, but it's just me presenting on this category. The idea here is to really provide a greater number of webinars that are a bit shorter and a little less content all at once to really make MIPS more digestible. So one presenter typically per webinar, so you'll definitely hear from Bridget and Kimmy at our later categories as well, and they'll be on the line helping with questions and answering questions in the questions panel of the control panel as well throughout the webinar. But the idea is to make this whole program more digestible and understandable. This was actually a request from one of you all on our YouTube channel. See, we really do listen to what you all want. So this week's Lunch and Learn is on the quality category. Before we get started, we have to share the announcement from Monday of this week. If you're not on the CMS listserv or you don't follow us on LinkedIn, you may have missed that CMS officially announced the COVID-19 hardship for 2023. We were very unsure if they were going to allow this hardship again in 2023 since the public health emergency is set to end next week, but it looks like they have moved forward with it again. Now, I am hoping I don't see our numbers just plummet off the call right now because, well, yes, this would actually allow you to not report in 2023 and not receive a penalty. It also allows you to report on only 2 categories, meaning you can exclude from cost for a full score, which is huge. This means we get to go into submission, picking likely either PI or quality paired with our improvement activities, knowing exactly what our score will be when we submit. We will not have these flexibilities in future years, and there are Medicare reimbursement cuts going to effect, and those actually, a 2% sequester has already been in effect since July of 2022. So our recommendation is to participate and try and offset these cuts by earning a high score and therefore a positive payment adjustment. You can apply for this hardship in your QPP portal, just as previous years, but don't forget, if you apply for the hardship, any data you submit or it's submitted on your behalf is going to override that reweighting for any performance category, and then that category is going to be scored. So just keep that in mind, be cautious. Okay, back to today's presentation. Had to share that announcement with you all. This is our first of our Lunch and Learn series. Since that's the case, I did include a bit more of a full MIPS program overview than we'll have on all the rest, just to make sure we're all starting off from the same place. So a quick vocab lesson to start. While most of us throw out the terms MIPS, MACRA, Quality Payment Program, QPP, kind of use them interchangeably. I get a lot, will you help us with MACRA? They really are not interchangeable, and they do mean different things. So to clarify, for the sake of the rest of the presentation, let's kind of break this down. The Quality Payment Program, or the QPP, was enacted under the Medicare Access and CHIP Reauthorization Act of 2015. We call it MACRA. So as you can see, the Quality Payment Program is then comprised of two participation tracks: the Merit-Based Incentive Payment System, or MIPS, which we're talking about today, where clinicians receive a performance-based adjustment. Alternatively, see what I did there? We have the Advanced Alternative Payment Model track, which are innovative payment models that have their own unique program requirements and a lump sum incentive. These are programs that typically force your practice to take on some sort of financial risk. Think of things like CPC Plus, the Medicare Shared Savings Program, any of those tracks, A through E, or really any sort of accountable care organization. Now, the Merit-Based Incentive Payment System, or MIPS, this track, or really the traditional MIPS track, is what we're going to be talking about today. It was developed to improve patient health outcomes by tying payments to quality and cost-efficient care, with the overall intention to really increase the use of health information, and then, therefore reducing the cost of care. Believe me, we of all people know MIPS sometimes gets a bad rap. It's just another set of requirements. It's more clicks or burdensome workflows. And I hear you, but at its core, this program does work to improve patient care and outcomes. If MIPS was a person, and if you've been on my webinars before, you've heard me say this joke, but I would say they've got a really good heart. It's the thought that counts here. There really is good intention. And if you think about it, if you are following the workflows, you are likely performing more screenings on your patients. You're having to take the extra step to provide that education, to document those follow-up plans, or place the necessary referrals for patients to get credit and continue, that ongoing patient care. Now, on the administrative side, this program consolidated all the legacy programs that we used to have to report on into one. We used to have PQRS, value-based modifier, and of course, meaningful use. Now we just have MIPS, which each one of those legacy programs aligns with a category under the current program. So those categories are what determine your final score, and we will be focusing on quality, or the old PQRS program, today. Okay, so on to the information we have to know about MIPS. So first up is going to be eligibility. You're eligible to participate in MIPS if you're a MIPS eligible clinician, or one of those types listed on the screen, and you also meet the other requirements, which we're going to go over next. So if you're not one of the clinician types listed on this slide, you're excluded from reporting under MIPS, and you're not going to be penalized. This list has grown a ton since the beginning of this program. So make sure you're double checking that, as this eligible clinician category has broadened. But if you are a clinician type listed, or you have these clinician types at your practice, you may have to report for them. And it depends on a few things. So first is going to be your NPI and your tax ID. When you join a practice and reassign your Medicare billing rights to a tax ID, or what we call a TIN, your NPI becomes associated with that TIN. And this association is referred to as the TIN NPI combination. Fascinating. Didn't see that title coming, I know. Now, if you reassign your billing rights to multiple TINs, or basically stating you bill Medicare Part B claims under multiple different tax IDs or entities, you'll have multiple TIN NPI combinations. So Basically, if you practice at more than one entity, CMS is going to evaluate each TIN and NPI combination for MIPS eligibility. So you'll have to check the eligibility status at each one of those combinations. Now, to determine eligibility, CMS actually reviews past and current Medicare Part B claims data and PACOS data. They actually look at these twice for each performance year, and each review, or CMS calls them segments, analyzes data from a 12-month period. And that analysis of data from segment 1 is released as your preliminary eligibility determinations. That's what's out right now. Analysis of data from segment 2 is then reconciled with the results from segment 1 and released as your final eligibility determination. And you can see what date ranges we're currently working with for 2022 eligibility in that screenshot on your screen. Now, you might be wondering, what are they looking at our claims for to determine eligibility? Well, in order to be fully eligible and therefore required to report, you have to be one of the previously listed clinician types. And then during both of these segments, you need to be over what's called the low volume threshold. So the low volume threshold is the volume of covered professional services, Medicare patients, and associated charges a clinician or practice must exceed in order to be MIPS eligible. So you have to participate in MIPS if in both of those 12-month segments of those determination periods, you bill more than $90,000 for Medicare Part B covered professional services, and you see more than 200 Medicare Part B patients, and you provide more than 200 covered professional services to Medicare Part B patients. Notice I never said or, always and in here. You need all three. I do want to point out that these thresholds are the same at both the individual NPI level and the group level. So if you exceed all three low volume threshold criteria as an individual, you're eligible for MIPS and you're required to participate and report. If your practice exceeds all three low volume threshold criteria as a group combined, your practice is eligible for MIPS and can choose whether or not to participate as a group. Notice individual is required, group is optional. Now, if you or your group exceed one or two of these criteria, but not all three during one of those segments, you're not required to report, but you have the option to actually opt in to participate in MIPS if you want to. Some people I know are thinking, you are crazy, Lindsay, no chance I would choose this. If I didn't absolutely have to, if I didn't have a penalty looming over me. But you'd be surprised. We actually assist a very large number of opt-in clinicians because they're doing the required documentation and workflows, and they want the extra incentive money to help offset their Medicare fee-for-service reimbursement cuts. You know, that negative 2% sequester went into effect last July 2022, and we've got practices reaching out saying, I want to participate in MIPS because I know that if I get an incentive or a positive payment adjustment, it'll offset this so I can keep my practice in business. So it is something to consider now more than ever, even if you find your providers are not actually required to report. Even more of a reason to this year with the hardship, you can take cost out of the equation, which is the only score we can't calculate before submission. Now, the good news is there is a simple way to check if you're eligible. It's what's called the QPP NPI lookup tool. So this is what we use when we assist clients with MIPS reporting. It's actually found on the Quality Payment Program website, which is the most helpful and informative website CMS has ever created. They really got it right with this one. I can't stress enough, not only does this website have this awesome NPI lookup tool, but so much more, their webinar library, their resource library, etc. Now, when you search an NPI, it will come back and show you if a clinician is eligible for MIPS or exempt. And their clinician details listing provider types and associated tax IDs, as well as their practice details. So the practice details section is where we find information on this clinician if they have any special statuses or different designations like rural or health professional shortage area. It also gives you a practice versus an individual breakdown, and you may be asking why. And I think I already gave myself away, but that's because clinicians are able to report two ways under MIPS, either as an individual or a group. If you report as an individual, you report under your NPI TIN combination, and you get a score and adjustment unique to that combination. Now, if you report as a group, you are reassigning your rights to that tax ID or TIN. So you would submit one data set that aggregates all the data from your tax ID, so all your clinicians combined, and then everyone gets the same score and everyone gets the same adjustment. Now, once you've figured out if you're required to report, and then if you will report individually or as a group, you need to know what you're reporting on. So under MIPS, you're required to submit data on 4 different categories. The first is quality, then promoting interoperability, improvement activities, and then lastly is cost. So the quality category is basically the old PQRS program. This category is going to consist of quality measures like documentation of current medications, blood pressure screening and follow-up, tobacco screening and follow-up, depression screening, diabetes eye exam, etc. The PI category is the old meaningful use program, and it contains measures like e-prescribing, patient portal access. Then we also have improvement activities. This category is actually the only one under MIPS that did not stem from a legacy program. It's completely new. And then we have cost, which is the old value-based modifier program that measures spending and utilization for practices. So your performance across the MIPS categories, each with specific weights and requirements, which you can see on the screen, at least the weights portion, will result in a MIPS final score of 0 to 100 points. And that final score is going to determine if you receive a negative, a neutral, or a positive payment adjustment. So your MIPS payment adjustment is based on your performance for 2023, and then it would be applied to your payments for any Medicare Part B covered services beginning January 1st, 2025. So there's that 2-year lag, and we'll talk about that timeline later on as well. Now, one special status, I know I've been mentioning the words or the phrase special status a bunch, that I do want to point out under MIPS and would likely apply to probably the most people on the call today if I had to pick one special status, and it's the small practice designation. So you're considered a small practice in CMS's eyes if there are 15 or fewer clinicians billing under your practice's tax ID during one or both of those 12-month segments of that MIPS determination period. If you are a small practice, you're going to earn 2 times the points for each improvement activity you submit. If you submit at least one quality measure, they'll automatically give you 6 bonus points in that category. And then you actually qualify for automatic reweighting of the PI category to 0%. So in summary, lots of perks if you're a small practice, basically. So now there was a point for that slide being there. What does the reweighting look like? So you saw the traditional category weights 2 slides ago. This is what the category weights look like for a small practice. You can see here things shift around a little bit. So I know you might be saying, we're here to talk about quality, Lindsay, not PI. What are we doing? But again, no angry mob needed. When this reweighting happens, you can see it actually increases the weight of the quality category. And when cost and PI are reweighted to 0, which can happen with this hardship, for instance, this year, the quality weight goes up even more. So just showing how that weight can shift, and it typically always shifts towards the quality category. Okay, so enough about weights and the whole program. Let's look at the quality category specifically. So the quality category is worth 30% of your final score, unless, again, you're a small practice or you submit that EUC, which we just talked about. You have to report on this category for a full year, meaning January 1st to December 31st, we are tracking data for a score. Now, there are a total of 190 plus measures to pick from, and you only need to pick 6 to be scored on. You can also elect to report on specialty measure sets. All you have to do is report on the measures that are included in that set, or up to 6 if there are more than 6 included in that set as well. What a lot of people don't understand is how to select those top 6 measures and score them, which is what we're going to focus on. But I want to clarify right away, gone are the days for really any of these categories that if you hit a certain percentage, you pass a measure, or you get 1 in the numerator or something like that, you pass a measure. That's not the case anymore. Now you need to score as high as possible on every single measure to try and get that incentive payment. So some updates that we saw in 2023 for quality specifically was the addition of 9 quality measures. A lot of these actually focused on kidney health, but there was a new one focused on social drivers or social determinants of health and screening patients for this. So I did want to point that out just because I feel like it could apply to a lot of people on the call. This is a new one that was added that I'd be on the lookout for. There were also substantial changes made to 75 existing measures, meaning even if you've been reporting on the same measures for years, please check to see if there are any changes to the requirements or how or when data is being collected. And then lastly, there was the removal of 13 quality measures from traditional MIPS reporting. 2 of those were just removed from traditional MIPS, and you can still report on them under the MVP track, but we're focusing on traditional MIPS today. But these did include some big ones that have been around for years. So influenza vaccine reporting, pneumococcal vaccine reporting, those 2 have been retired under traditional MIPS. You can still report them under the MVP, but no longer under our normal MIPS category. And then the diabetes medical attention for nephropathy, that was always a big one for clients as well. That one has been retired. And many more. Again, we can send out resources for listing of everything that was removed. Or if you go to our previous webinar, MIPS 2022 and beyond, they have listings in there. There was also a change in scoring. There will be no more 3-point floor for quality measures, meaning unless you're a small practice, you can now earn 1 or 2 points on a measure with a low performance rate. So before, last year, the lowest you could earn on a measure was 3 points. Even if you had a 1%, you still got 3 points. Now you can actually earn 1 point or 2 points. And then lastly, there was an increase in the data completeness threshold. Doesn't take effect until 2024 and 2025, but it will jump up to 75%. So what does that all really mean? Now, if you attended our MIPS math webinar a week or so ago, you already know, but for those who didn't, or maybe need a refresher, we need to speak to how quality measures are scored to understand those changes. So I think we're familiar with the concept of benchmarking, but in this scenario, your performance on each quality measure is assessed against a benchmark to see how many points you earn for that measure. Meaning, you will look at your performance rate on your report and you will compare it to the benchmark table that specifically aligns with that measure CMS has created, and it will tell you how many points you earn out of 10. So again, I kind of gave this away, but you might be wondering who creates these benchmarks, or at least how they're created. I think we probably all knew CMS establishes them, but they do release new benchmarks every single year. So the benchmarks for each collection type are based on performance data from a baseline period. That baseline period is actually going to be the 12-month calendar year, 2 years prior to your performance period. So what does this mean? The historical benchmarks for 2023 were established from quality data that was submitted for 2021. So whatever the nation submitted in 2021 is what controlled our 2023 benchmarks. Now, even if there was a performance, data collected or submitted back in 2021, the 2021 and 2023 measure specs have to be comparable, meaning there can't be any significant changes to the measure between that 2021 and 2023 time period in order to create one. If there were significant changes, then we won't have a benchmark for that measure, and that happens more frequently than you'd think. Especially if they change an IC10 code that's included or something, they're going to take away that benchmark. Now, I mentioned collection type. Benchmarks are actually differentiated by collection type, meaning there may be different benchmarks for the same measure if it can be reported through multiple collection types. So we'll go through the differences between these types of collection methods next, but know that based on how you submit a measure will impact which benchmark is used for scoring. This complicates things massively, right? Because a 100% on one measure may only earn you 7 points, but a 45% on another measure might actually earn you the full 10 points. So you can see why it's so difficult to understand your own data in this category, because you can't just look at your report and pick the top 6 with the highest percentage. It's now all about the benchmarks. So as promised, let's take a second to look at the collection type, since they will determine your benchmark, which will determine your points and your score. So again, the collection type is going to refer to the way you actually collect data for a quality measure. So an individual quality measure may be collected in multiple ways, and each collection type has its own specifications for reporting that measure. Now, most measures you'll see can actually be collected in multiple ways, and you can report measures from multiple collection types to meet quality reporting requirements. So you can kind of mix and match here. So let's use some terminology that makes sense to us, right? The first collection type is ECQM. I think we've all heard of ECQMs, or electronic clinical quality measures. ECQMs, if we look at this collection type, this measured data is collected at the point of care in the electronic health record, specifically an EHR that's certified by ONC. Data is collected for all patients that qualify for the measure, not just Medicare patients. Next is Medicare Part B claims measures. Measured data is reported on Medicare Part B claims when they're submitted for reimbursement. Now, please note, Medicare Part B claims measures can only be reported by solo practitioners and small practices, which, as we know now, means 15 or fewer clinicians. And data for Medicare Part B claims measures, I think this is a little bit obvious, but it's only reported for Medicare patients. Then we have MIPS CQMs, or MIPS clinical quality measures. Measured data may be gathered from paper, electronic charts like your EHR, or even collected with the assistance of a third-party intermediary like a registry. Data is collected for all patients that qualify for the measure, again, not just Medicare patients. And then next is QCDR measures, or Qualified Clinical Data Registry measures. So QCDRs are actually CMS-approved entities with the flexibility to develop and track their own quality measures. So because many QCDRs are really specialty-based, QCDR measures typically are more meaningful and applicable to your practice. Data is collected in a manner usually specified by the QCDR, typically for all patients that qualify for a measure, not just Medicare patients. So examples here to make this resonate: IRIS for ophthalmology, Regent for ENT, DataDerm for dermatology. I could go on, right? These are all QCDRs. They may support MIPS CQMs or ECQMs as well, but when you see a measure begin with IRIS, like IRIS 2 or IRIS 4, those are the QCDR measures. And there are more collection types, but these are the 4 main ones we wanted to hit on, and I would say probably 99% of you are likely using. So the biggest question my team and I get asked is, what is the difference between ECQMs and MIPS CQMs? Since I know some EHRs really support both of these, or you have options for both of these. And the main difference is the technology used to collect them. ECQMs are EHR only. MIPS CQMs can be collected via EHR, but you can also come from other sources, like a registry, like I mentioned. ECQMs also typically focus on codes, specifically a SNOMED code, whereas MIPS CQMs are typically more workflow-based. So while you may be reporting on BMI, you got the patient's height and weight. If it's out of normal range, above or below, you add, follow-up. You can use either the ECQM version of the BMI measure or the MIPS CQM version, and they have different benchmarks and different ways your system is tracking performance. And because of how they're tracked, your performance rate, if your EHR splits both ECQMs and MIPS CQMs, for instance, I know NextGen does, your performance rate is going to be different between the two. And they're going to earn you a different amount of points based on the benchmarks, because the benchmarks are different. So I know it's confusing, but it is important to understand there is a difference between the 2 collection types, even though the measures align and track a lot of the same things. Okay, so back to earning points using benchmarks based off collection type. What does a quality measure have to have in order to earn points? The basics are it has to have a benchmark. Seems obvious, I know, but not all of them do. It has to meet the case minimum, and it has to meet what's called data completeness. So let's start with the easiest. The measure has to meet the case minimum, which is a very fancy way of saying the denominator has to be over 20. So since the reporting period is a full year, this means you need to have at least 20 patients or visits, depending on the measure, included in that denominator over the whole year to be scored on it. This makes sense since obviously a measure with a 200 over 200 means more, it holds more weight than a 1 over 1 for a clinician or a client. And it's really a better indicator of performance. Next, it has to have a benchmark. Not all measures actually have a benchmark, and this changes every year, right? CMS releases new benchmarks every single year for various reasons. For a measure that does not have a historical benchmark, CMS actually will try and create or calculate a benchmark based on data submitted for the current performance year for that measure. So if there is no benchmark calculated, you will not be able to be scored on it unless you're a small practice, then they'll at least give you 3 points for a measure. Again, just kind of another perk here. So if a measure doesn't have a benchmark right now, you could still, again, submit it as an extra measure in case they create one, but we can't bank on it. And then lastly, the measure must meet data completeness. So what does data completeness mean? Data completeness refers to the volume of performance data reported for the measure's eligible population. So when you're reporting a quality measure, your submission, the data you send to CMS must identify the total eligible population outlined in the measure specs, right? So your denominator. And then to meet data completeness, you then have to report performance data. So telling them if the patient met, if they didn't meet, or if they were an exclusion, for at least 70% of your denominator. So incomplete reporting of a measure's eligible population, or really what this breaks down to is misrepresenting a clinician or group's performance, AKA you're only submitting favorable performance data. This is referred to as cherry picking. The CMS wouldn't consider it to be true or accurate. They're going to subject you to an audit. It is illegal, basically. I do want to note before anyone freaks out, data completeness, it's specific to the measures you report, right? So Medicare Part B is only going to be Medicare patients, and then the QCDR, the MIPS CQM, and the ECQMs are going to include all payer data. But again, don't worry too much about this. I know it sounds confusing and scary, but if you're using a certified registry or a certified EHR, they're either usually requiring you to report on 100% of patients. They're not giving you the option to manipulate your data. They're being pulled into a certified report, and that's that. You're going to report on 100% of this. You're in no danger of this. Again, no way to cherry pick. Or even if it is a certified registry and you're doing more of a manual upload process, they usually tell you where you are, compared to that 70% requirement for each measure. I know Bridget works with our premier clients on our registry, and we are able to see exactly where we are with that data completeness threshold as we upload data. So once you've identified measures that have a benchmark, they're over 20 in the denominator, and they meet data completeness, you're going to want to then actually use the benchmarks to assign points. So points are determined by mapping the performance rate to the benchmark for that measure, specific to the collection type. So let's look at this process closer, right? This is a screenshot and extract from the 2023 benchmarking file, and it's showing the range of performance rates associated with each decile for each collection type. So you want to determine the decile that the performance rate falls into for a measure submitted, again, based on collection type. They say if you say it 7 times, it'll stick. So in this example, we have measure 128 with a collection type of MIPS CQM and a performance rate of 99.46. Again, we're going to look at specific to collection type. If this measure was reported as an ECQM, it would be compared to a different benchmark than the same measure being reported as the MIPS CQM. You can see for this one specifically, there's no benchmark for the ECQM version of this measure, which is CMS 69. Oftentimes, one benchmark is more favorable over the other when you're comparing ECQM and MIPS CQM. So if you have access to both of these collection types, the benchmark should play a huge factor into your selection of your top 6 measures. Meaning, give an example here. If you can get 80% on a measure for the full 10 points using the ECQM version, where you would have to get 100% for the MIPS CQM version of the same measure, you're going to want to pick the ECQM version to focus on and track throughout the year. That makes sense, right? We're trying to pick the measure that we can score the lowest on and get the most points. So long story short, benchmarks control everything in the quality category. Your score, your measure selection. I mean, really, your entire reporting strategy should depend on this benchmark file each year. When this thing is released by CMS, it is like Christmas morning on our GI team calls. I mean, I swear we have a tracker on it. This file is huge. So again, to bring it back to this example though, we have identified decile 6 for this measure, which means it will earn 6 out of 10 points because that's where the performance rate falls. Now, you just need to repeat the assignment of these points for each selected measure. Easy, easy peasy. Once you do one, you'll be fine. And then you actually want to sort and group your measures based on points, not performance rate. Again, your hierarchy should go with your most amount of points first down. Your goal is to have 6 10-point measures for your provider or your practice to report on at the end of the year. Please note, if you achieve this early in the year, let's say you run your numbers right now and you've got 6 10-point measures and you're like, I'm good. I am done with MIPS. Woohoo. No way. Remember, you need to maintain this score throughout the entire year. So yes, that would be awesome if you can get 6 10-point measures right now, but then you still need to be deploying maintenance and education to make sure it stays at that same caliber throughout the whole year. And then don't forget as well, if you are a small practice, you get to add those 6 bonus points to your quality category score. There actually used to be more ways to earn bonus points for everyone in this category, but those were removed starting last year, which was a bummer. Made things a little bit more difficult. Now, once you have your top 6 measures selected, and they aren't all 10 points potentially, right? We need to figure out how to get your final score. So you would actually add all the points up and then divide by 60. So 60 is the total number of available points. Now, there are some scenarios where this may change, but for our exercise, let's say we earn 49 points across our 6 measures. But we're a small practice, so we're going to add 6 points to that 49. That means we've earned a 55 out of 60 for quality. Not bad. Since the quality category is weighted at 30% towards our score, I know we're a small practice, but we're gonna go ahead and submit our PI too. We would take 55 divided by 60, which would give us a 0.92. Take that decimal, times it by our weight, which is 30%. We're at 27.5. So based on the benchmarks and our points earned, our quality category score that contributes to our final score is a 27.5 out of 30. Okay, since we know what's required, we know how to score our measures, let's look at our best practices to succeed in this category. Some of our secret sauce, if you will, that honestly we don't want to keep a secret. We want everyone to succeed. So first is measure selection. This is crucial. Here really, I guess let's flip it, right? What are the measures you want to avoid when narrowing down your focus or selecting your top 6? So keeping in mind our goal is to get 6 measures that are 10 points each. To do that, you should try and not report on measures that have no benchmark, since you're only going to earn 0 or 3 points if you're a small practice. Now, I mentioned this, but if you want to submit a measure that has a really high performance rate, but there is no benchmark, for instance, like I said, the BMI measure, the ECQM version of that measure has been removed this year. We definitely have clients who have a super high percentage. We've been reporting on it for years. We recommend you submit it as an extra measure in case they do create a benchmark and it would score higher than one of your other top 6 measures. You don't want to report on any measure with less than 20 in the denominator, again, for obvious reasons, as you would not be scored. And then for the reason we just went over, you don't want to report on measures that have a low performance compared to their benchmark. And I stress the compared to their benchmark portion because that measure could have a 97%, and you might really want to report on it. But if you can only earn 4 points for that 97%, and another measure with only 55% would earn you the full 10 points, you need to go with the 55% one. Remember, it's all about the benchmarks. Speaking of which, in the benchmark file, there are measures that are what CMS refers to as topped out or have a 7-point cap, which we usually want to avoid. Let's start with topped out. If a measure is topped out, this means a large percentage of clinicians in the historical benchmark data set achieve the maximum performance rate. These benchmarks are then identified in the benchmark file with one or more of those deciles having dashes, and then decile 10 has 100%. So you can see an example on your screen. The higher the percentage of clinicians that met that maximum achievable performance rate, the more deciles will show the dashes. You can still earn 10 points on a topped-out measure. You just have to make sure you earn 100% exactly. So if you're at 100%, absolutely use it. Use it in your top 6. Let's get the 10 points. The issue is when you're at 99.99% and you only get 5 points. So banking on those measures are really difficult as long as you can achieve that 100% and maintain it throughout the entire year. The last type of measure to avoid, unless you're a small practice, is a measure capped at 7 points. Measures that are topped out for 2 consecutive years are capped at 7 points, even if your performance rate falls in deciles 7 through 10. Weirdly enough, the benchmark file still displays values for deciles 7 through 10, even though the measure can't earn more than 7 points. Very strange, misleading, I know. But again, the last column on the spreadsheet will state if that 7-point cap is a yes or a no, so you can't overlook this. Again, if we think about this, we want 6 measures that are 10 points each. So if a measure is capped at 7 points and we report 1, we're already short 3 points from a perfect score immediately. I mentioned small practices can report on these only because they're given those 6 bonus points that could make up the difference. But again, you don't want to report on any more than 2 of those measures or else you'd be forfeiting 100%. So outside of measure selection, overall monitoring of performance is key. You need to be running your quality reports regularly. Our advice is monthly or more, but the main point is you cannot wait until the last quarter of the year to run your reports or try to improve. This program, and specifically this category, requires constant work. It's like a house plant. It requires love, attention, water, sunshine, all the things. And shockingly, I cannot keep one alive, but not a problem, as I promise I can keep our clients on track with this category, as long as you're willing to meet and work on things consistently and work through it together. You need to review measures and make sure performance is going well, or figure out how you can improve it, either by going back, and working some of these, encounters or visits, or working on education for staff who need it and workflow training to improve it going forward. Again, this is not, the 12th hour that you can run these reports. You would be, trying to climb an upward battle or fight an upward battle at that point. Another huge success we have seen is when a practice communicates to the providers and their clinical team how they are doing and how performance has increased. This gains buy-in. It allows everyone to work together. It sometimes creates some friendly competition. But really, we've been involved now with a lot of practices who actually send out the results of, we've increased our performance by 5% over the past 4 weeks. And it really lights a fire and gets everyone, working on the same team and rowing in the same direction. And lastly, do not just pick 6 measures. A measure could lose a benchmark or be suppressed at any time. So just make sure you pick a few more. We recommend 7 to 10 to track throughout the year. And then lastly, for submission, make sure you pick the collection method that will earn you the highest score, and don't be afraid to mix them. You cannot mix collection types for PI, but for quality, you can. You could submit 3 ECQMs, maybe throw in a QCDR specialty measure if you need, and if you're a small practice, why not throw in a claims one? Always utilize the method with the benchmark and performance rate that works best for you. And then one note here, especially if you submit the EUC or that hardship, maybe you don't want to submit quality as your 2 categories. Maybe you want to do PI and IA. Make sure you check the QPP to see if there is claims data in there. Because if there is, it will count as a quality submission as soon as you upload data in another category. So just make sure you remember, if you're a small practice, you may be submitting claims data and not realize it. And check the QPP before you upload PI and IA data. I cannot tell you how many clients we save from penalty by doing this, or how many clients have come to us from getting a previous penalty because of this. I know I can already see in my head Kimmy and Bridget shaking their head furiously. Yes, yes, yes. So this is a big one. And then lastly, we just had a few FAQs we wanted to throw in here and share regarding some nuances of quality that we've gotten from clients before. So first question, it's an easy one. Are all topped out measures capped at 7 points? Not the case, no. A measure is capped at 7 points when it's topped out through the same collection type for 2 consecutive years. So that 7-point cap is applied in the second consecutive year. So what this means, right? A measure may be topped out without having it being capped. Just keep note, if you're only reporting on topped out measures, there very likely could be a 7-point cap added for next year. Next, when do we report our data? So this is key. So your reporting period is the whole calendar year. Then you're going to submit your data to CMS in Q1 of the year following. So for 2023, we're going to submit your quality data to CMS January through March of 2024. Then we'll find out your final score and your payment adjustment in the summer of 2024. So that's July or August of 2024. And then that adjustment will actually take effect starting January 1st, 2025 for the whole year. So you kind of see why that 2-year lag has to be. So for instance, we are getting close to-ish, getting our 2022 final feedback and payment adjustment coming up here in the summer. So sorry, a lot more information provided than what was asked, but that is the timeline for the program for each year. Next, and these last two, I will warn you, are a bit more advanced, but we do get them a lot. So what if I don't have 6 measures to report on? So our team's first reaction is going to be, well, let's look at your specialty measure sets. Can you meet the quality reporting requirements by reporting a complete specialty measure set? Some specialty measure sets include fewer than 6 measures. That's why we say that. If you are having trouble finding 6 measures, there's a chance that, like I said, that set might already have less than 6 and you weren't aware of it. Now, there's a chance that even some measures in your specialty measure set don't apply to you. So CMS does say, if you report all the available measures that are clinically relevant to you, and it's still not 6, CMS will implement what's called the EMA process, or the Eligible Measure Applicability Process, to review the measure data you submitted and determine if there actually were any other quality measures you may have been able to report on. So the EMA process is applied to those who reported Medicare Part B claims measures or MIPS CQMs. Keep that in mind, only those 2. And they actually might result in a denominator reduction. So, right, saying you only have to report 5 measures instead of 6 measures. So keep that in mind. This is only, again, for MIPS CQMs and claims measures, but you may be eligible to report less than 6 measures. I know we had worked on some clients this year that we went through the EMA process for because of this case. So great example. We see this a lot with CRNAs as well. And last but not least, a big one this year, since we know a lot of practices are switching EHRs or are being acquired or merging, which may mean a change in EHR. So what if we switch EHRs in the middle of the year? If you transition from one EHR system to another during the performance period, you should aggregate or combine the data from the previous EHR and the new EHR into one file for the full 12-month reporting period before you submit that data. Again, maybe you didn't even switch EHRs, but if your practice uses multiple EHR systems under your tax ID and you report as a group, you'll still need to aggregate data into a single report prior to submitting that data. If a situation arises where data for the full 12 months is unavailable, so think if the data can't be aggregated from both systems, it's just not possible, you should still submit as much quality data as possible. Just keep in mind the 12-month performance period and the 70% data completeness threshold are applicable regardless of an EHR transition during the performance year. So what CMS is trying to say is that if you can't meet that, submit what you can, so you're scored at least a little bit. You're getting some points to try and at least limit or lower your penalty. Again, if you can't aggregate the data, you're basically just trying to stop the bleeding and report what you can. And please note, an EHR transition during the performance period is not the reason for a hardship. Also, please keep in mind for 2023 performance period, the EHR system you use can have the functionality of the 2015 edition cert for ECQMs. However, the submitting EHR system must be certified to the 2015 edition Cures update criteria before the ECQM data is generated for submission. So a lot of people think they only need to upgrade this year for the PI category. And with this hardship, they're doing a happy dance saying, I don't have to upgrade anymore. I'm not doing PI. That's not true. You also need to be on this new Cures version for the ECQMs as well. Okay, so with those clarifications in mind, those kind of FAQs, I hope we're feeling okay, but if we are feeling a little overwhelmed, that's completely okay. I mentioned earlier that this is our full-time job. We have a whole team dedicated to this for our full-time job. And I'm sure most of you on this call, it's not your full-time job. So good news is you don't have to do MIPS alone if you don't want to. Your DAS GI team is here to help. We have all kinds of assistance packages to best suit your needs. We can do ongoing, we can do as needed. And again, ongoing support would include everything. I don't know, MIPS support from start to finish, right? We would do data analysis, report retrieval, custom monthly reports, quality measure training, workflow training. We would be meeting on a regular basis and even willing to teach your practice resources, the program, to try and bring it in-house or gain a better understanding of it in the future. Really, we really just want to help. So that's it. We did make it. If you're asking yourself what your next step should be, please, we recommend you visit our website and continue to sign up for our webinars, especially our category-specific ones over the next few weeks. They make understanding the program a lot more manageable. I know this one did go a little bit long. There will be less of a MIPS intro on the future ones. And if you do want another set of eyes looking at your data or taking this over for your practice, just consider working with our GI, our government incentives team. You'd be working directly with myself, Kimmy, or Bridget. Just reach out to your DAS account manager, or if you don't have one yet, you can email us directly. So here's our contact information. Like I said, don't hesitate to reach out, or if you have a follow-up question you didn't get to put in the chat. We did want to open the floor up to questions from you on the quality category. So if you do have a question, feel free to type them in the questions portion of the control panel now, and then Bridget, let me know if there were any you and Kimmy have not been able to answer yet, or if there are any you guys wanted to read out.
Yeah,
let me know.
I think we have a couple good ones. The first one, let me get this together. So what if they're reporting for MIPS, but they want to report a combination of ECQMs and MVPs for the flu and pneumonia? Can they use a combination of the ECQMs and MVPs?
So I can grab this one if you want, or Kimmy or Bridget.
Oh, if you, that's fine. Anyone.
I was just going to say, so the MVPs portion that I'm sure you've all been hearing about is actually a completely separate reporting mechanism than MIPS. It's a very similar program, but you actually have to enroll in an MVP. It's a value pathway based on specialties or conditions. So if you report a certain number of ECQMs, they likely will count for both. So you don't have to report it exclusively, I guess, if that's what it means. You can report both traditional MIPS and both the MVP pathway this year and get scored on both. Whichever is higher will be your final score. So if you are reporting on ECQMs, they likely will count for both programs. Does that, Bridget, does that seem like that answers the question?
Yes, that is 100% perfect, yes. Another one that I thought was interesting is we have a client asking regarding like what version they need to be on for like next gen or even eClinical Works. Kimmy, do you have those versions available of what they need to be on? Okay, thank you.
Yeah, so for next gen Office, it's 5.0, and then the other version of next gen is going to be 6.2021.1. And I just have a couple of other ones too I can add. For all scripts, it's going to be version 22 or higher. Athena will be 22 or higher, and then eClinical Works is 11.5 or higher, and then Aprima is going to be version 19.20 or higher.
Perfect. And yeah, if you guys have any other questions about that, just feel free to reach out to Lindsay and we can get that information over to you as well. Lindsay, as of right now, I think those are good. The other ones are more pertaining to practices specifically. So I think that those were good questions. Thank you guys.
Awesome. Well, thank you so much. We'll give you a few minutes back, and we hope to see you all on our next Lunch and Learn on the Promoting Interoperability category. Thank you. Bye.
Bye.